thought we could start off by asking you, as a medical expert, how these drugs actually work in your body. I mean, we know they suppress appetite, but what are they actually doing?
Great question. And I just want to take a step back and kind of frame the introduction of the drugs in the concept that obesity is a disease, because I think that's so important for understanding how they work and also the cost and who should be on them and all of the societal implications. So it turns out that our bodies regulate our weight in a very tight fashion. So this is a physiologically regulated variable. And we have mechanisms to drive energy storage, eating food, and we have mechanisms to stop ourselves from doing that. And GLP-1 is a hormone that our bodies make. It's made in the intestine. And it's very interesting because in the pancreas, it helps us secrete insulin. In the brain, it gives a signal to slow down eating. And so GLP-1 receptor agonists are medications that mimic this hormone that we make. And so originally they were developed to treat diabetes because of their effect on insulin. And then it was also applied to obesity because they go to the brain and they tell our brains to slow down eating, that we don't need any more fuel. So they suppress appetite. They may also be having a lot of other effects, which we can talk a little bit about. But that is the main way in which they work. But a really important thing is that they're not just effective for losing weight. We really need to think of them in their importance for maintaining the weight that you lose. Because really every individual has this weight set point. So a combination of genetics, hormonal, biological, environmental factors, which determines where our weight wants to be, where our physiology is regulating our weight to. And what these drugs do is they lower that set point. So by telling our bodies that we don't need to eat more, they're also saying we're okay at this lower weight. We don't need to invoke all of the mechanisms to go back to the higher weight. And so they help people lose weight, and they help the weight set point be lower so that we're not driving all of those eating behaviors.
So if these drugs are lowering your set point, essentially, does that mean that if you go off them, your set point will go back up? And in other words, does it mean once you're on these drugs, if you want to maintain a lower weight, you have to stay on them for the rest of your life?
So this is such an important question, and I think kind of a hotly debated one. But in the scientific community, the data is very clear. The medications work while you take them. So again, taking a step back, we are programmed to store energy to survive. And so the reason we have this weight set point is to survive. It drives the behaviors that we need to keep our stores in stock. So when you lose a lot of weight, in a way, even though it's often what we want for the individual, it's in a way a physiologic crisis where our bodies are like, wait a second, we don't have enough here. And we invoke all of these mechanisms to gain weight back. For example, we drive hunger hormones. We can measure these hormones. We know they're higher after you lose weight. So what these medications do of lowering the set point, that only works while you're taking the drug. So that's kind of the theory behind everything, right? You need to continue to take them for your body to continue to feel like we're okay at this lower weight. We don't need to increase the hunger hormones and all those other things. We also have scientific evidence because these trials have actually been done. With semaglutide, Wegovy, and with tirzepatide, they've given the drug to people in clinical trials. They show significant weight loss results. And then when you stop the medication, the patients in those trials regain the weight. And at Form, that's what we see when we treat patients. If they have to have a stop in their medication because of coverage or something like that, we see people start to regain the weight back. So this is really, really important. Now, we need more science, and it doesn't mean that an individual patient can't work with their healthcare team to try to do it, to try to continue to do the behaviors that they've been doing on the drug and try to get off it or get on a lower dose. But as a kind of strategy, we know that you need to have continued use.
So Form Health is part of this new Lilly Direct program, right? could you explain that partnership to us? And you have said there's some misconceptions about it. So what are those?
Yeah, thank you so much. So Form has been very proud to be featured on the Lilly Direct website and to be in this relationship with Lilly where patients are being exposed to the opportunity to get high quality evidence-based clinical care. So really, what this relationship is trying to connect the patients who need obesity treatment with a team that is able to deliver that care. Where I have felt that there are misconceptions is that there are actually multiple aspects of this program. On Lilly Direct, there's also an opportunity to find not telehealth, in-person care teams, and there's also a pharmacy where people can fill a script and it gets delivered to their home. But Form is not a place where people come just to get a Zepbound prescription. We are very proud and also invested in delivering comprehensive care. We believe that there are many tools in the obesity treatment toolbox, so people do not come for one prescription and that's it. We will, really understand each patient's medical history. We will do comprehensive evaluations, and we really arm them with all of the tools that are available to treat obesity, and that is the goal, to treat obesity and drive health, not to give a specific prescription. We use all of the medications, not just Eli Lilly medications, and our clinicians treat every patient the same. We don't actually know at the clinician level where the patient came from. They may have been referred by a doctor. They may have seen us on Lilly Direct, and we will explore all the options that the patient has and decide with them what the right treatment is for them. It may be no medication. Some people don't want to use medication, even still in this Ozempic era. And it's very important to combine medications with nutrition, physical activity, behavior change to drive the best outcomes.
Well, how commonly are you and your team prescribing Zepbound, and are you prescribing it more than Wegovy?
Okay, great question. Again, we really make the decision at the individual patient level. And a big component of deciding the treatment is understanding the patient. What's the right treatment for them and what do they want? But then there are other aspects that also determine what the patient has access to. Some patients don't have insurance coverage for certain medications, but they do for some and not others. So we're really kind of looking to understand the entire patient, what they have access to from a medical perspective, from a cost perspective, and then trying to find the right treatment. So I can't say we're prescribing one type of medicine more than another type of medicine. I can say that I think it's really important to be making the individual decision. Sometimes there's an opportunity to switch treatments when patients aren't doing very well on one treatment. I think one thing that's not very commonly advertised is that some people actually, while these medications are a phenomenal advancement, really a scientific revolution, and would love to talk a little bit more about that, they're driving such tremendous impact for many patients. There are some patients who don't respond or don't respond optimally to a specific medication. Then we might consider switching them to another medication. So again, I think it's really about this individualization of care.
And I think you've told me before that actually most of your patients, what percentage is it, are not on a GLP-1. So what percentage is it that there are on GLP-1s?
At Form, 10 to 15% of patients are not on medications at all. They're using the what's typically called lifestyle tools, so nutrition, physical activity, behavior. A big percent of patients are on older generic medications. They cost less, but they can help. Again, we're trying to drive health and treat obesity, not put people on a specific medication. So about 40% of patients end up on the GLP-1 receptor agonist class of medications. And that's in part also, again, driven by coverage, because less than 50% of people in the US have coverage for these newer, more expensive class of drugs.
More expensive drugs. Let's talk about you as a telehealth provider for a little bit. So this question comes up all the time. How, as a telehealth provider, do you evaluate patients when people can lie about their weight to qualify for a prescription? I mean, people lie about their weight all the time.
It's true. It's true. Well, okay, fantastic question. Telehealth is a care delivery mode. So all that telehealth means is how you're delivering the care to the patient. I think what's really, really important is that we still think of this as medical care for a metabolic disease, which is obesity. And so, at Form, what we're really interested in doing is expanding access to high quality, evidence-based care. And that is different from a mail order prescription or a fake knockoff of a prescription or something like that. So when we talk about telehealth, we still want it to meet all of the standards of high quality care that you would think of. So the professional who's treating you should have all the right credentials. All of our physicians are board certified in obesity medicine. You should be able to get in touch with the people who are giving you this prescription. I mean, these medications that we're talking about today are not without side effects and complications. And so if someone is, getting a telehealth option where they can't even get in touch with a provider after they've been getting the prescription, that is really concerning. At Form, we review the patient's medical history, we connect with the PCP and get records to really understand the person's medical history and be sure that this is, safe and interactions with other medications and things like that. And that's, I think, the kind of quality metric that people should be really looking for, that it is, a professional with the right credentials, that you can get in touch with him. And I think it's so important to think about the treatment of the disease. I mean, obesity is a disease, but it's also a risk factor for hundreds of other medical, issues. And so what we're thinking about is the whole health of the individual. Does this person have prediabetes? Do we need to link into that? Does this person have sleep apnea? Do we need to think about that? And it's really thinking about the individual and how we can drive better health. That is the focus, as opposed to, driving a specific number on the scale.
Well, and how do you monitor their progress? I mean, okay, you're getting their records from their primary care provider, but once you're treating them, you're not seeing them in person. So how do you monitor or verify the progress they're making? Like, what tools do you have to do that?
Well, we are seeing them on Zoom. So we do, real video visits. At Form, our patients have visits with their medical team and with a registered dietitian, and that is very important. But actually, this is where telehealth, I think, is so exciting, because the amount of data that we can collect from patients, our patients get a digital scale, and every time they step on the scale, that gets translated to them in their app and then to us. And so we have a tremendous amount of weight data and also other biological factors that will enable us to really, understand how people react to obesity treatment and how they do. And we can also use the technology to give them, educational modules that are really individualized to what they're going through at this step in the journey. So telehealth definitely can, help us track people much more closely than we used to do in the old days at brick and mortar. But also, very importantly, I think because you asked me kind of how do you follow them, the emphasis is also on health markers, not just weight. So we are following metabolic markers, for example, hemoglobin A1C, to watch their prediabetes resolve, or high blood pressure, or blood pressure metrics to see if their blood pressure medicines, their blood pressure is getting better, thank you, and we may be able to take away blood pressure medicines, which is, one of the really great things about treating obesity to improve health, is we can take medications away from people who no longer need them.
So demand is so, as we said, so intense for these drugs. How long does it take right now for a new patient to get an appointment with Form Health?
Great question. We aim to see patients within about 10 days of when we receive their medical records. We do, because we are trying to provide high quality medical care, we are collecting information about the patient, connecting, as I said, with their primary care doctor, and gathering information. We have to verify a lot of information about their insurance because our care is fully reimbursed by insurance. And so all of that paperwork takes a little bit of time, but after that, we are able to see the patients very quickly. We've had a lot of interest in patients coming to see us, and so there is, high demand right now. It may take a little bit longer during times like this, and then we kind of settle back down to our goal.
Well, and another question about demand is that, we know there have been supply constraints of certain drugs over time. So what kinds of issues do your patients have filling their prescriptions? Can they fill them? Are you dealing with that a lot?
This has been, really, really difficult because in some regards, we are just in this incredible phase of having all of these new treatments for patients. And one of the things we didn't talk about is that actually GLP-1 medications have been on the market since 2005. We had an early twice daily injectable approved in 2005 for diabetes. In around 2014, the first one was approved for weight loss, liraglutide for treatment of obesity. That's driving 6.5% or so weight loss. In 2021, we get semaglutide approved for obesity, and the average weight loss in trials is 16%. And now with tirzepatide, we're seeing an average of 20 to 22% weight loss. So this has been such a remarkable evolution on the impact for patients that these drugs can drive, but at the same time, we have significant access issues. So there's the coverage issue that we've been talking about, and then there are the shortages. So, I might meet with a patient, one of my colleagues might meet with a patient, we might go through a comprehensive treatment plan to address all of the different lifestyle factors and decide that a medication is the right next step, settle on which one, after, again, considering a lot of options, and then realizing that we can send the prescription to the pharmacy, but the patient can't get that medication. And so we're having to be very creative. Sometimes we have to use medications at a different dose than we would have chosen. Sometimes we have to start on one medication and cross over to a different medication. Sometimes we can't use that medication for patients at all. And very troublesome is when people lose access in the middle of treatment because of what we talked about before, that in general, when you come off medication, your body drives your weight back up. And so, someone having success using the medication for some time and then getting into a situation where lack of access, insurance, or shortages means that they have to go off the medication, that is very, very troubling.
Do you think, we're going to go to questions in a few minutes, so everybody prepare your questions for Florencia, please. Do you think Medicare will eventually cover the cost of these GLP-1s?
Well, I truly hope so. So Medicare has had, because Medicare usually drives what other insurance companies will do. Medicare has had for decades this kind of rule that it doesn't cover medications for anorexia, weight loss, or weight gain. But I think really where we need to sort of shift is to see these as medications for obesity. And the recent data that semaglutide lowered cardiovascular disease, cardiovascular events and deaths by about 20%. This is the kind of thing that we need to focus on. We're treating a disease, we're treating the downstream complications, as opposed to the number on the scale. Medicare covers bariatric surgery, and there are other government bodies that cover, including the VA system and the Office for Personnel Management. So I think we need to kind of standardize and move forward. And there is a bill, the Treat and Reduce Obesity Act is, being proposed as a way to include and broaden access to obesity treatment, not just medications, because it also includes the lifestyle piece, but include medication coverage.
So a couple minutes ago, and we'll go to questions after this, you walked us through how these medications have changed over time and improved in their effectiveness. So I want to ask you, what's in the weight loss drug pipeline now? What are we going to see 3 to 5 years from now?
Yes, so this is really exciting, and I think also really highlights why it's so important to work with a treatment team who are experts and knowledgeable in obesity, because as I also mentioned before, maybe patients will need different medications or change over time. I see some really exciting broad categories. First of all, GLP-1 is not the only axis that drives weight regulation. So we're seeing development of drugs in different classes. We're learning that combinations of therapy often drives better results than single agents. I think we're going to be able to focus on not just weight loss, but quality of weight loss. So some of the drugs in the pipeline are specifically medications that will help boost muscle mass. And there's been all this talk about, the concern of reducing muscle mass. So that's very exciting. Another really exciting thing is these are biologic. The GLP-1 receptor agonists are biologic medications. They're very expensive to produce. We're now seeing small molecule production, and data starting to come out on this kind of class could mean the cost comes down a lot. And then finally, kind of longevity, treatments that last longer. We've already gone from twice-a-day injection to once-a-week injection, but there are studies thinking about driving gene therapy, maybe leveraging our own production of GLP-1, stimulating with gene therapy to drive the production of GLP-1 in the body instead of taking it exogenously. So there's just a tremendous pipeline of research development, drugs, and other strategies for treat obesity, which is really exciting for patients who have obesity and who really need these different treatment options, and also really exciting for people in the field. And my colleagues and I at Forum are just so excited to be able to continue to help the patient find the right treatment for them.
So much discovery about how this all works biologically, and so many new findings coming out.
Yes.
So let's go to questions. Please raise your hand and a mic will come to you. When it does, please stand and give us your name and where you're from. Right here, Esther. Right over here in the middle.
Oh, okay. Esther Dyson, Wellville. Very briefly, we've been talking a lot about costs, and clearly they're likely to go down. We also, I hope, will be talking about savings to make some of these coverage decisions change. How much, and it's too early to tell, there's a lot of issues about timing and long-term and so forth, but I'm sure somebody's already done a lot of little studies and counterfactuals about how much these drugs could save. That's a question.
Excellent. Okay, so I think what you probably mean is how much they could save in terms of cost to the healthcare system. So we're starting to get information about, we have longer term information about how weight loss and treating obesity can help save costs. And there's sort of different buckets, I would say, of how it can do that. One thing that we know is that obesity takes a huge toll on an individual, and individuals with obesity are more likely to be absent to work, more likely to develop complex medical problems. And so treating obesity is a way to make people be healthier and prevent very costly, kind of medical treatments that they'll need during their lifetime. I think a great example is prediabetes. You can reverse prediabetes through weight loss. You can greatly minimize the risk that that person will go on to develop diabetes, and diabetes is one of the most costly diseases that we deal with as a society. So we can see the costs reduce in that. It's very hard to give you kind of exact numbers because again, how much the medication costs is obviously a big part of this picture, and we're still figuring out what the actual costs of medications are. There's a whole, complex situation there. And because we are starting to learn really important things. For example, the SELECT trial results that just are very recent and showed this reduction of 20% in cardiovascular disease we need more information like that about prevention of kidney disease and all of the other things that are so expensive in society to treat. So I don't think we know yet, but I think that is a really critical question when we put this on the balance of, what does this cost? But again, I always bring it back to, we have to think about treating obesity as opposed to prescribing a specific medication, because there really are many options and there really are, multiple evidence-based tools. And we have to put it all together to really understand the costs, what the costs can be. Yes.
We had another question over here. Yes, right.
Oh, thank you. Oh, you have to hold it? Oh, I'm sorry. I'm going to talk a long time. So I just want to thank you for the presentations. And the previous speaker on health inequity, I just wanted to give a different perspective because my name is Dr. Morvin Beverly. I'm president of Morvin Beverly MD PLLC, Patient Engagement and Cultural Competence. And my way of looking at the process is from speaking to over 1,000 patients from all ethnicity across the large public health system. And I think we have to start looking at from health equity. Now there's nicer language. We started with health disparity, now we moved to health equity, and then there's non-compliant and now non-adherent. But what I call the boots on the ground solutions came from patients. And I think we have to look from what's the perception versus the reality of the population served. If the perception is not the reality, that patient or that population health is going to go south. But if the perception and the reality is the same, good, bad, happy, or sad, there's an opportunity to collaborate. And the reason I say this, and to understand that this is a fact, the Black population has the worst health outcomes in all disease categories. And the elderly Black population, when you consider the atrocities that they endured, they have the worst health outcome as well.
So we
we
have like 20 seconds left.
Okay.
Would you like her to?
Yeah, and I just want to, just one other point. Cultural competence is not a part, the Black population is not included. And just a quick the people that died in Brooklyn from all socioeconomics that were Black. Prince George County have a large, very affluent Black community, and COVID, they had the worst health outcomes. And so transportation runs through Black and white Brooklyn, and access to care got about 16 hospitals. So we have to look at it from not just from that lens, but a larger lens, and to recognize that cultural competence have to apply to American-born physicians, to foreign-born patients, but also foreign-born physicians to American-born patients, and American-born physicians to American-born patients who are different than themselves. Thank you.
Well, thank you. I couldn't agree more that health equity has to be essential in this conversation. And our mission at Forum, as I said before, is to expand access to obesity care. And that's, we're saying the same thing. It has to be for everybody. That's why we have to think about coverage in a way that's fair and equitable. And telehealth really allows us to deliver the care to all different parts. There are a lot of places in the US where there are no obesity experts. People have to drive a long time, have to take off work to come to care. So this is, thank you for highlighting these issues. I agree, this is how we have to be thinking about the problem.